Gracies, MD, PhD, completed his residency in intensive care, neurorehabilitation, neurology, and acute stroke care at Hospital of Paris, France, and received his medical degree and doctorate in neurophysiology from the University of Paris 6. After working 10 years as Attending and Clerkship Director in the Neurology Department at Mount Sinai Medical Center, Dr. Gracies took a position in 2007 as Professor and Chair in the Department of Rééducation, Neurolocomotrice at Hôpital Henri Mondor, Créteil, France. Dr. Jean-Michel Gracies is a world-renowned expert on the neurorehabilitation of movement. In his current position at Hôpital Henri Mondor, he is launching novel pathophysiological concepts, neurorehabilitation programs, and clinical research projects for syndromes such as spastic paresis, Parkinson's disease, tremors, peripheral facial paralysis, and other movement disorders.
You have a very extensive medical background and career to date. Can you tell us about your background, where you went to medical school, and where your career took you across the world and now back to France?
Right. So I was, I would say, a regular student in a suburban high school near Paris until I was 16. Then I had one year in which I studied only mathematics for 1 year. It's a system that doesn't exist in the US. It's called, in French, it's called classe préparatoire. It's preparatory classes. It takes you potentially to very high level science schools like in maths and physics. That lasted only 1 year because I felt I was not strong enough in maths to be really the top I wanted to be. And so I decided to go for medical school. I went to medical school in a well-known medical school in Paris called Pitié-Salpêtrière. And I did all my med studies there. And I left Pitié-Salpêtrière in 1984, then embarked upon my residency, which I did in neurology. In fact, the first couple of years I didn't do neurology. I did 1 year of very intensive care in those intensive care mobile units, you know, the trucks, the ambulance with the resuscitation intensive care within the ambulance. That's where I was working for 1 year.
Okay.
Then for 1 year, I was only in rehab, neuro rehab. And then I did my full residency in neurology proper, which is in stroke care unit, Parkinson's, multiple sclerosis, and general neurology. And I became a neurologist in 1992. I had then my regular certification as a neurologist. Within my mind, always an interest for neuro rehab because I had met very good people in that field. But at that time, I was just a neurologist.
Mm-hmm.
Then I did together, and in parallel with my residency, I could do a PhD. So I was medical doctor and medical and science doctor in 94. And then came the decision to leave France because I got into a small argument with my boss then. And I suddenly was not in a situation that I could continue in that particular place, in that particular department. So I was in fact led to look for fellowship elsewhere. And I ended up finding an interesting fellowship in Australia, where I spent 2 years with a professor called David Burke, who was a very well-known professor in spasticity research. And that was in 95, 96. Then I wanted to go back to France, but now I had no position yet. And I met this guy called David Simpson, who was at the time giving some seminars, some talks in Australia. We met and he said, why don't you come to New York? And I said, well, if there is any budget for me, if there is any job, I will. And there was a job, there was a fellowship. So I started a fellowship in one of the divisions of the Neurology Department at Mount Sinai in January 97. and it was the movement disorders division. And I started to learn about Parkinson's disease then and other conditions similar to Parkinson's. But because my primary interest in field was still spastic paralysis, spasticity, I continued to do both fields. Mm-hmm. And then one thing led to another. I went up the scale at Sinai. I was a fellow, then instructor, assistant professor, and slowly. And then I was about to pass associate professor with, you need letters of recommendation and stuff, when I finally got invited to take a position in Paris, which I had expected for a long time. At least I had waited for that. And that position was the one I'm still on now, which I'm very happy with, which is in a suburban teaching hospital just outside Paris, in Créteil. It's a relatively large suburb just outside Paris, similar to maybe if you were in Long Island, someplace close to Manhattan, not too far. And I run here a neuro rehab department. I moved disciplines. I became a rehab physician coming in France. I changed my certification to rehab. I'm still a neurologist by training, but became formally a rehab doctor. But of course, a neurologist rehab, a neuro rehab. And it's been now since 2007. I spent 10 years in New York, 10 super years in which I learned a lot and I had a great experience. And now I've been here 13 years in Paris, and I don't see the time flying, and that's it. So I'm very happy here in my situation of neuro rehab. I think it fits me perfectly because I had always this inclination for rehabilitation, but as a neurologist. And so I'd like to promote that discipline of neuro rehab, and I'd like more people from rehab or from neurology to become neuro rehab. I think it's a very useful and important discipline, and this is why I'm trying to promote it and the field of neuro rehabilitation.
Yeah, absolutely. I mean, your background's incredible.
It's a field where you basically use as little meds as possible, little pills, as few pills as possible, and as more physical work as possible to reshape the brain, to reshape the neural command. And you reshape the muscles by stretching, and you reshape the brain by training. And that is way more efficacious than many drugs that you would ever take by mouth. So that's why I moved into that field, which I'm very proud of, which is the field where you go down again in the meds. Basically, the pharmaceutical industry has really grown up with Rockefeller in the 1920s, 1930s. And I'd like to see a degrowth of it in the next few decades with people using less meds and more healthy life, healthy living, and physical work and things like this.
I would agree. So would you consider neuro rehab kind of the same division as in the States, what a physiatrist does?
Yes. What you guys call a physiatrist or a PM&R physician, we have the same discipline in France. In fact, you have to understand the discipline was created in the US. PM&R, Physical Medicine and Rehabilitation, was created in the 1930s in the US. It was created in France, for example, in the 1950s. Mm-hmm. But regardless, so now that discipline exists in both places, what is more rare, even in the US, is the people that are neuro rehab, that are trained in neurology and trained in rehab, to really try to take the best of both and combine them, which is the main thing. Right. And so when I was in the US for 10 years, there were very few neuro rehab guys. There were many rehab physicians or physiatrists, many neurologists, and very few that had tried to combine both knowledges and both disciplines. And it's kind of the same here. There are very few people who really have done both sufficiently well so they can really apply the knowledge of a neurologist to rehab and the knowledge of rehabilitation to neurological disorders. And I think it's a useful discipline for patients. And so therefore, I'm encouraging my pupils, the younger guys, to do that, because I think we have something to offer to patients.
I would agree. I mean, you're a pioneer in what you do. So your colleagues that are younger are gonna take on what you teach them and have taught them already.
Well, hopefully.
Oh no, they will. I promise you. Everyone has already that you've taught. I know firsthand from Dr. Odell. So you specialize in botulinum toxin
Yep.
for treatment of spastic paresis, or I should say tight muscles, for those that may not know what spastic paresis is, of an affected limb with hemiplegia or paralysis. Can you explain what botulinum toxin is and what the difference is between the toxin versus the traditional Botox that everyone knows for dermatological use?
Okay. Yeah, of course. So botulinum toxin is a protein. You know, you have in biochemistry, you have the lipids, the glucids, and the proteins. And the lipids is the fat, glucids is the sugars, and protein is the meat. And of course, there are many kinds of proteins, and we are made of proteins mostly. We have sugars in us and fats, but we have a lot of proteins. And bacteria as well. And bacteria produce proteins. And there is one bacteria called Clostridium botulinum or botulinum that produces a protein that is actually toxic. And if you get too much of that protein in your blood, it can paralyze all your muscles and you die by asphyxia because your respiratory muscles are paralyzed. Mm-hmm. And this protein is botulinum toxin produced by a bacteria called Clostridium botulinum that you can get from bad salads, bad sausages, foods that are not well conserved and that you eat when you shouldn't. And in the, let's say, a century ago, we knew less about hygiene, and botulism was a disease that was not rare. Today is very rare because hygiene conditions have improved, and in all our, at least in the Western countries, we have very good hygiene situations. It's not the case in other parts of the world, but in the Western world, we do have extremely rare occurrences of this disease. But regardless, in the 1920s, some researchers were able to show that botulism was due to that protein. And in the 1940s, particularly in the American warfare, when American Army was looking for biological weapons, the idea emerged to use some of these toxins produced by bacteria to see whether these proteins could be purified and injected in an enemy to kill him. It's a tragic thought, but that was the, you know, that's the armies and that's what they do. And they look for weapons that could be lethal and could put down an enemy. And in those years, in the 1940s, in labs, in biochemical labs of the US Army, there was this trends of research toward purifying some toxic that you could either make the enemy inhale or eat or drink or etc. And came the research on botulinum toxin, and some researchers, and their names were Chance and Johnson. They put together a technique to purify botulinum toxin, and again, this is in the 1940s. It remained confidential for a couple of decades, and the US Army, it seems, was not using much of that potential weapon because difficult to deliver. You need an injection, so you're not going to inject the Russians. It's not easy, and basically it stayed in the shelves in a way. And in the 1960s and 70s, an ophthalmologist came to be aware of the existence of that toxin, maybe through research project he was doing, and had the idea that if you used very minute, tiny amounts of this toxin, you could be useful by injecting specific muscles that were overactive. And he did that in monkeys, with the strabismus, when you know your eyes are squinting. And if you inject very tiny amounts of the toxin in small eye muscles, you could correct some of the strabismus. He did it in monkeys and then in children with congenital strabismus, and there was some success there. And that's the beginning of the story of botulinum toxin. Then 10, 15 years later, neurologists came to be aware of this pioneer's work. His name was Alan Scott. And they started to say, well, in neurology, we have many conditions with overactivity of muscles, and we could maybe use it then. Okay, and that was the case in the early 80s. Some neurologists started using the toxin in the US and then in England, and particularly in spastic paralysis, where people may have muscle overactivities. And the first paper, the first article was written by two English physicians, Dace and Park, and they published their paper in 1989. In 1989, I was a young neurology resident in Paris, and I became aware of, maybe not that paper at the time, but the fact that some people were researching on botulinum toxin. We had I remember a symposium in Clermont-Ferrand, which is a town in the center of France. I was like 26 years old. I was a young neurology resident, and I got the opportunity to attend this small symposium. Maybe we were 12 or 15 guys of us, talking about a drug that nobody knew, botulinum toxin. Very few people knew. And I remember myself saying, well, but this is genius. With this thing, we can avoid having patients take all these depressant drugs, these synaptic depressors that are going to weaken up the whole brain and the whole muscle commands. And we can just inject the toxin just where it's needed, without the need to spread a toxic throughout the nervous system, but just in one muscle. And to me, it sounded like a genius idea. And I pushed and pushed and pushed. In those years, I was just a resident, for my boss to use that thing, to know where to get it and to use it. And finally, in 1993, I was now a young fellow in Neuro Rehab already then. I got the information that one company, it was an English company called Porton Down, was making a toxin called Dysport. The commercial name was Dysport, and I got some vials of it, and I started my first injections. I didn't know how to inject, and I injected, the way I could. I didn't know how I did that. But anyway, this was 93, and I did my first couple of injections, and it worked. And the patient, I remember it was a lady patient who was very young. She was 25, 26. She had a scissoring gait. She had cerebral palsy, so stroke, perinatal stroke, stroke at birth. And when she was walking, her legs were scissoring, and I injected into her 80 doctors, and she was less scissoring afterwards. And I said, wow, this is great. It works. And the lady patient would say, well, it is helping me. It's good. And then came my change in career. I couldn't stay in Paris anymore. I had to find a job. So I did that fellowship very remotely, 26,000 kilometers away in Sydney, Australia. And I talked to my Australian bosses, and I said, we must study botulinum toxin. We must use that toxin. This was 1995 now. And they say, botulinum what? What is this? And I said, botulinum toxin is great. And I was trying to encourage my bosses to let me work on that. And it was a bit difficult. And finally, they let me have one day of my week where I could, 4 days of the week, I was doing their thing. And one day I could do my thing, and I could try to participate, to associate myself to a very burgeoning initial clinical study that an American company was organizing then. It was Allergan, it was Botox. And so then I started learning Botox, which is a one brand, just like Dysport is another one, like Citroën, Chrysler, and Fiat. These are all cars, but they are brands. And so Botox is one of the brands, and it's the American brand, the leader of the market. Dysport is another one, and then came Xeomin, which is the German toxin, and then other one, and then the Chinese, Japanese, Korean toxins, and etc., and Russian toxins. So nowadays, we're 25 years down the road, and there are many brands, many toxins across the world. In the US, you basically have access to 2 or 3. In France, we have 4 with the Neuroblock. But when you go to Brazil, you have 7 toxins. And when you go to several different countries, you have different access to different toxins. So it's all cars, it's all the same principle. And pretty much personally, I only have experience with 4 toxins: Botox, Dysport, Xeomin, and Neuroblock or MyoBlock in the US. Well, that's enough, because already you have a panel of, there are slight differences between the different toxins. So anyway, so between 1995 and today, well, people have studied, there have been a lot of clinical research done on botulinum toxin. We know better what it does, what it does not, whether it's sometimes a bit risky or dangerous, or badly tolerated if you use too much. And so we know better what dose not to go over, or which dose below which there's no effect. And we have learned over the past 25 years how to refine our use of the toxin. If I take my own example, for example, in 2007, 6, 7, 8, when we could see each other relatively often, I was one of the guys who was using high doses, very high doses, because I thought the drug companies are too cautious. They don't want problems. So they say, well, don't go over 360 units. And I was saying, well, this is ridiculous. We can use 500 or 600, no problem. And I was going to 400, 500, 600, 700 units. When I arrived in France, it was 2007, I pushed to 800. And I got my first side effects. I said, whoa, calm down, Jean-Michel, you're going too far. And I went down, and now I would say I have followed a curve, and I use on average a bit less than I was using 10 years ago, but certainly more than was recommended 15, 20 years ago. So all of this goes to say that there is a learning curve of all of us, all the toxin users. And we have learned the technicality of injecting it, how much were the dose that will be good, and why inject this muscle and not that one, etc. So we had to learn our job. It's, to me, it's arts and crafts. It's something between, it's not art, but it's not pure science, because you do need to have a lot of experience doing it. There are things that are not sometimes very much rational, but you know why you won't inject that person there and you will inject this one. So there is a experience, arts and crafts. And I think that's what toxin is. A good toxin user is a guy who is a good, the French word is artisan. So you're skilled in arts and crafts. You're a skilled person.
Sure. I think more doctors definitely need to be more arts and crafts with the toxin, because not everyone is. It takes time and practice.
It does.
Attention to detail.
It does. It does. The fact that it's manual, it's a manual work, it adds a dimension to what we have to learn. Mm-hmm. We have to have some knowledge there, some experience there, and some practical skill as well. And so that's another dimension to what we do.
Yeah, no, absolutely. So I guess, quote unquote, in layman terms, so what type of conditions do you use botulinum toxin for? And I guess, can you give us some examples of when you inject the toxin into X muscle, what that will help, in terms of spasticity, and then also, mobility?
So the first condition, of course, is spastic paralysis. In other words, let's take the example of a paralytic hand. Your hand is kind of too bent like this. You would like to open it, or to open it sufficiently to take a big object like a cup, a mug, or a bottle, or a glass. Mm-hmm. And you can't, because your hand is too cramped, because the muscles that are what we call the extrinsic finger flexors are overactive. They are too active, and particularly just when you would like to open the hand, they co-activate, and that's called co-contraction. And if they co-activate at the wrong moment, you'd like to open your hand just sufficiently to grab the cup, but you can't. And so there's not enough opening. So then you can inject botulinum toxin in those finger flexors at the right dose. This is what I was saying, not too much, but not too little. Mm-hmm. And if you do it well, the next day, the patient can grab the cup. That's I would say, the universal example of opening the hand enough. And so in spastic paralysis, you do have these situations where some muscles are overactive and co-contract too much. And those are excellent indications where you can really make a difference within a month, because before the injection and 3-4 weeks after, you see the difference. It's like a nose in the middle of the face, you see it. But there are other conditions where toxin can have sometimes an even more spectacular effect. Let's take the example of people with Parkinson's disease. They take meds, medication, levodopa, dopaminergic drugs. And sometimes, particularly when the dose goes down between 2 unitary dose, with the dose of, say, 2 p.m. and the dose of 6, well, at 5 p.m., the dose of 2 p.m. has gone down, and you begin to developing some dystonic activities. For example, the toes curl like this, and it can get painful. It can be bothersome because you cannot walk barefoot because it hurts you when you step on your own toes. It's a bit hurtful, and a good injection there in the toe flexors can really release this, and patients say, wow, I can dance the tango barefoot again. So those are indications where the doses used are even lower than in spastic paralysis, but with sometimes even more clearer benefits and sometimes spectacular benefit, because there is no paralysis. It was just a question of releasing overactivity. Another indication that is very, very clear is people with tremors. So they have tremor. You could argue it's overactivity of 2 muscles on either side of the joint. Let me mimic a pronation supination tremor. Well, if you inject just the pronators, for example, the quadratus that's right here, or the teres that's right there, somewhere here, you can markedly reduce tremor, markedly. You don't inject supinators, you inject just the muscles on one side, and you can see disorganization of your tremor. So where you had this, you have only that. It's still a bit tremulousness, but it's much less than it used to be. And so that's been discovered, I would say, in the late 90s, but there are relatively few, I say relatively few tremor injectors. There are some in the neurology teams, of course, but I believe that the toxin as a treatment for tremor is still underused today, not well known, not perhaps enough established in the literature, particularly because people have injected both sides of the joints, and we really promote only one side that's sufficient to disorganize the tremor and stop the large amplitude tremor that can be bothersome for patients. Anyway, tremor is a very important indication. There are many other indications. I will cite 2 more. Sometimes you can't swallow well, and your saliva accumulates in your mouth. And when you have some neurological disorders like advanced Parkinson's or again cerebral palsy, so stroke at birth, you have a drooling because the muscles, the swallowing muscles, are not functioning well, and so you end up having too much saliva in your mouth, and there are patients who drool. And then you can inject the salivary gland, the submaxillary gland here, or the parotid gland there, that can dry up your saliva just enough. You don't want to do too much, because if you dry up all saliva, you can have candidosis and you can burn your mucosa. But you have 4 major glands. There are 6 or 8 glands, but there are 4 major ones: submandibular, and parotid. And if you inject just one submandibular, that's enough to markedly reduce your saliva amount, and then people stop drooling and they are relieved for 3, 4, 5, 6 months for very small doses. So it's a very, I would say, clean and effective indication, very easy technically to do for physicians. And the final indication I will quote, which is quite well known, is people who sweat too much, and you have sweat glands in the palm or under the arm, and it's very simple to do. You use very small needle to create as little pain as possible. Sometimes you do some median nerve anesthesia before the injection to make sure patients will not have pain when you inject. It's not, you don't need to anesthetize much under the arm, but here it's very sensitive. You may need to anesthetize the median nerve. You inject a few spots there with very tiny doses at each spot, and you can remove the excess sweat. So those are also indications that are not FDA approved for some of them, but that we do practically very often because they are clearly useful. Well, I mentioned here 5 indications. There are more, but spastic paralysis, Parkinson's, tremor, sweat, drooling, those are very classic indications. They are not all FDA approved for all brands of the toxin, but they are always useful. I will mention a final one, which is the people who have hyperactivity of the bladder muscle. They tend to, when their bladder fills up with urine, to feel like they need to go too quickly, and you can loosen up the detrusor, the muscle of the bladder, and that's also an indication that's not approved for all brands, but that's approved for some of the brands, and you can inject inside the bladder. You need cystoscopy for it. You need a specific technique, and that can be useful for many patients with bladder overactivity.
Wow, so many.
So that many, but I mean, there are many, many more. There are,
I know.
If you had to put an exhaustive list, it's probably 25 or 30 indications. But I mentioned to you right now the 5 or 6 that are really the major ones.
Oh, wow. I didn't know that there were so many.
I'd like to put a word of caution. Botulinum toxin, to me, may not be a revolution, but it's a very significant evolution of our field, of the field of neuro rehab. And really, we have spared many systemic agents by mouth because just local injection. So for me, it's a big step forward for many patients.
Right.
There is a word of caution. If you do too much toxin, you may have feelings of fatigue, and you may increase the falling. You may, in a way, disrupt the balance reactions, particularly when injecting the lower limbs. And then you may increase the incidence, the risk of falling for some patients who are already at risk. Mm-hmm. Just to tell you that, like with any drug, like with any medication, there are drawbacks, and there is some caution to exert. And you learn from the papers you read, the articles, and you also learn from from your personal anecdotes and your clinical experience.
Right.
Just to say that it's not like anything, it's not a miracle. It's something that must be used properly with some thinking, the benefit of experience. And this is what I meant to say. It's not just let's go ahead and inject everything that moves. It's right. You have to be cautious enough when you do this. Even with a focal treatment, you need cautiousness, even more with systemic drugs, but even with focal treatments.
Are there any other side effects aside from maybe a little bit of fatigue or some, I guess, spread, quote unquote, of the toxin to the other types of muscles that you inject?
Yeah. So fatigue, I said, spread to neighboring muscles. That's a well-known adverse effect, and you need to design properly your injection volume, how much dose, how many sites, etc. So this is the arts and crafts we talked about. There is the slightly increased risk of falling, which was not well known until a couple of years ago. This is studies I participated in myself in the past few years that have shown that you have to be cautious with people who already have a balance impairment before you inject. These people, you really have to inject little or not at all, because you may increase the risk of falls. I'd like to mention another potential adverse event that's not known, and that is only quietly so far mentioned in the literature that I wrote, which is my conception of it is that the toxin creates some stress. I call this a stressogen. In other words, you inject toxin. If you inject high doses in fragile patients, you see their heart rate slightly going up and the blood pressure slightly going up as well. It's not big numbers. And for the general population, you barely see it. But because I've been the lead investigators in a number of international trials in the past 10 years now, since I've been in France, I have been given access to some data that I didn't know before. And I could see that although those are small effects, I would say for a person who is fragile from a cardiac point of view, particularly the heart, you have to be cautious. You do see in a group of population, in a population, that your heart rate creeps up a little bit, your blood pressure doesn't go down or creeps up a bit. Well, that's in a population, but for one single individual, if that's a person with a fragile cardiac condition like coronary, like people who are subject to heart infarcts, you want to be cautious. These patients, if in their individual case the heart rate goes a bit too much up or their blood pressure, you may put them at risk of cardiovascular problems. Again, what I just said is not well known. It's not even so clearly written, except if you look at the papers I wrote, which we mentioned, but we cannot make it, we cannot put a black triangle saying, well, don't inject anymore the toxin. No, but you have to be cautious in those patients who have a fragile cardiac condition, because I believe that the toxin, like any proteins involved, even vaccinations in general, you do create some increased metabolism in a way for a few days or a few weeks, or what you could call, very loosely said, stress. There is some stress that you inject in your body. So in a young, fit person, no problem, but in an older person or in a person who is fragile from a cardiac point of view, I just exert a word of caution for this reason. I think you do cause some stress in the body that could be important to know in someone who is fragile or frail or some elderly person.
Absolutely. You are very special in what you do, and you now have trained X, Y, and Z doctors that post injections, instead of just running with it and letting it, go up to its peak and then let it wear off. You emphasize the importance of a self-guided rehabilitation program, which you do have a book.
Guided self-rehab, yes.
Guided self-rehabilitation program. Sorry. You have a book coming out. Congratulations. In June, I feel like I was like the baby, like, while you were creating all of this. I remember this years ago. But anyways, congrats. It's amazing. Can you tell us a little bit about this program that you and your other colleagues created with you?
So it's relatively simple. The basic idea is to give responsibility to the patient. In most of the modern world in which we live, there is a sort of trend for de-responsibilization. The drug companies tell the government, you buy my vaccine, but I don't want to be accused. If ever there are deaths, I have nothing to do with it, at least from a judiciary point of view. Well, it's a symbol of the whole society. Nobody wants to be responsible for anything. Well, if you have a stroke, I'm trying to teach patients, to tell them that, in fact, they will be responsible for their progress if there is any. And that's going to be hard work. That's their duty to do this hard work. And so the first word is responsibilization. You make patients responsible for the progress they will have done between two visits, 3 months apart or 2 months apart.
Right.
The way to responsibilize the patient is to make them intelligent about their disease, understanding the pathophysiology and the anatomy of the disease. Where is this muscle? Why is it here and not there? Why this one and not that one? What is the type of activity it has? Why this overactivity came up? And so it's like patients should become specialists of their own problem. And so my job and the job of my pupil is to teach patients visit after visit in a way that's adapted to their previous levels. I'm talking about educational levels, because we can always adjust the way we teach, like for students. There are young students and older students. There are specialized people and not specialized. So you adjust the wording you use, what you say to the patient you have in front of you, but you certainly give the patient a weapon, an intellectual weapon, to understand the disease he or she has, And therefore, to facilitate this responsibilization, when I know what I have, I can take better charge of my own problem. And finally, you give them the technical weapons to how to stretch that particular muscle, how to train this particular muscle. And so the final step is the teaching of the techniques of stretching and training. Once you have the three things, you have made your patient a more intelligent person about his or her own disease. You have given the techniques to the patient, then suddenly the patient has nothing, no other possibility other than being responsible for what he or she gonna do. And then you review the patient often. You don't let the patient go for 6 months or 2 years, because then, no. The thing, it's like growing a flower. You will feed the patient every so often with new teaching, with new knowledge, with new encouragements to make this a growing flowers. To make this a growing flower, the patient's brain is growing in terms of intellectual understanding of the disease, in terms of increased motivation and increased technicality. How do I do to stretch that muscle? Could I use that technique or the other? And when a patient has learned, patients teach me things. They invent stretching techniques or training technique I didn't know. And you believe it or not, but in the past 10 years or 15 years, some patients have taught me techniques that I then give to others. And so, because some patients are more advanced than others and are more creative, and they come up with things that I say, well, this is great, and I had not even thought of it myself. And then I can use this technique for another patient.
Right. Yeah, no, well.
And so we call it guided self-rehab contract. Guided because you're here as the guide, whether you're a physician or a physical therapist, you can be the guide. So you need a guide. You're not left alone.
Right.
Self-rehab because it's your responsibility to do your stretch. And we have proven in a to us a very important paper published in 2019 with Maud Pradine as a first author, Pradines. It was a PhD that I was directed in those years. We have shown that self-rehab, provided it's done for long enough, 1 full year, has significant benefit versus as against conventional way of doing your therapy with a patient coming and doing your movement for you. No. Here you do your own movements, you do your own stretching. And we have shown in a controlled trial that this was more effective in lengthening, loosening up muscles and improving movement than, I would say, conventional rehabilitation where the therapist comes to your home and does this for you, or you see the therapist in her practice. And so guided, you're there. Self-rehab because the patient does it. And why contract? Because the patient provides to you a diary, a quantified diary of what he or she has done. And this diary is the symbol of the work he or she has done. It's the reawakening. Every morning when you wake up, you see the diary of yesterday, you say, well, I'll have to do better today. And this diary is actually part of the encouragement that you give to yourself. You know what, when I was preparing for my competitions, for my final exams in med school, we had a very difficult final exam in France called internat. You guys in the US, you have interviews. You have to, when you're a medical student, you have to interview in many places, in many residency programs, and there is what you call a match, which is the depending on the way you perform in your interviews, your interviewers ranked you among others, and you ranked your programs, and there's a match. Well, it's a different system in France. You have a ranking that is only based on a written exam, but a very difficult one, and you are 7,000 students every year that are ranked, basically, if I may simplify, from 1 to 7,000. And the first one picks any discipline he wants in any town or program he wants, and the last one takes what is left. And so it's a very hierarchical system. You're ranked, and you have to work very hard if you want to be among the first, to have the choice of your discipline and the city you want to work in. Mm-hmm. And so when I was preparing for that competition in those years, this is the 85, 86, 87, without knowing it, I was doing a diary. Today for endocrinology, I worked 46 minutes. Then I I had 10 minutes television I saw some bullshit on television. I came back to my desk and I did 64 minutes of gastroenterology. And then I did neurology for an hour and a half, etc. And I was writing down everything I was doing. And in fact, when one full week had passed, I said, well, on average, this week I worked 7 hours and 36 minutes at my desk. Well, I need to do more than this next week. And it was helping me. Well, it's exactly the same system. You're helping yourself by writing down what you do and don't do. You have to be very honest. And most of us are very honest people. When you're just facing yourself, you can't be anything else but honest. And you did, oh yeah, well, I didn't work enough yesterday. Well, I did good. Let's do it the same today. And it's always an incentive to do better, or at least as good if the day or the week was good. And so it's useful as a positive reinforcement, as a way to encourage yourself to do even more. And we call it a motivation maintenance tool, a motivation increase, and then motivation maintenance tool, the diary. So contract, because you give back a diary to your therapist or your physician, and in exchange, the physician gives you explanations, encouragement, technical knowledge, anatomical knowledge, physiology, all the knowledge you need to understand your disease, and it works together. And this way people make sometimes spectacular progress, sometimes good progress. Yeah. And sometimes no progress, rarely, when they don't do anything and when you don't see them in 6 years.
Right. Yeah, no, I think it's important. I mean, I'm a prime example myself. I mean, so I think what's really important is that, I mean, you can make amazing progress if you're very dedicated. Let's put it this way. Mm-hmm. Every day you see your doctor, so it'd be me to see you every few months, injections and whatnot. And I think you can testify, like you've told me and you've seen me and your other patients, but you can make permanent progress, quote unquote, to a point where maybe you don't need as much toxin anymore.
Exactly. The point is that after a few years, you start realizing you don't have to inject every time, or you can drop the dose, and one day you stop injecting altogether. And right. I have this history with a number of my patients today, and this is very comforting when you see that you don't have to rest on some chemical that you have to inject, but you have done so much work in your hand or your arm or your leg that finally, well, the daily work is enough to maintain your performance. Mm-hmm. You see, we use a particular scale. When you look at the upper limb, we call the modified French scale, and you have a score. That scale grades your function between 0 and 10. And my observation after a number of years is that people who reach 6 or 7, they can just live, because at 6 or 7 score, they begin involving their hand in their daily life, and that involvement is the rehab. Below 6, well, it's difficult because the hand is in a too difficult situation. You don't involve it, so really you have to work hard on it. But there is a threshold past which, well, that's it. If you are interested, I could share the screen with you and show you a couple of patients right now. You could see what I'm saying when I say that. There is a threshold of improvement beyond which basically you're safe. You passed on the other side of the world, and your hand is back into your life. It may not be exactly as good as the other hand, but it's good enough to be involved in daily life. And that's the goal we have each time.
Right. So this program is obviously tailored to each patient, but it's not just, a 15-minute program. It's something that can be up to an hour and a half.
Oh, yeah.
A day.
Absolutely. Yeah. Intensity is part of the program. Quantity, amount. Mm-hmm. As someone was saying, past a certain quantity is a quality. In other words, if you reach a threshold of quantity of work, of amount of work, suddenly you see the improvement beginning. So you have and qualitatively your hand begins to be different. So amount is important. The notion of quantity, of intensity, of difficulty is important. The work must be difficult. Mm-hmm. if you can, in fact, if you have an easy work, easy exercise, it means it's a wrong exercise. It has to be each time difficult.
Right.
And as you just said, then motivation has to be a part of it, because to do something difficult, you need an amount of motivation.
Of course.
And the main tool for that motivation to us is the diary.
Right.
Is the diary combined with the regular encounters with your physician or therapist.
Right. What now are you actively involved in? So you have a book coming out. You're on the board of the Neurotoxin Rehabilitation Association. You're a professor. You do everything. But what are you actively working on now?
I'm telling you, my first, I would almost say obsession today, my first goal is to create what I would call a school, and to have sufficient pupils that believe what I say and that follow in my steps. And I think I have a couple who do that right now, but I'd like to have a bunch of good, solid, strong pupils of mine, so that when I go one day, these guys take over and multiply the effects of what I have tried to do with the guided self-rehab.
Right.
That's the first thing. It's not exactly a scientific goal, it's more a sort of educational goal.
Right.
Now, in terms of medical work, I do have an objective, which is to finally get my second book out, which is the Parkinson's book, which is, I have written for the past 12 years, a similar book like the one on spastic paralysis. I have written a book on Parkinson's disease, but for Y, Z reasons and disorganization of a busy life, I've not dwelled on it, focused on it. It belongs to the thing that I've put on less urgent matters, but now it's becoming more urgent again. I need to leave that book on Parkinsonism because the population of people affected by this disease, which I happen to have learned quite well as well, it might be useful for them to have this type of guidebook as well. So that's more of an educational tool that I like to promote and to publish. And in terms of pure scientific work, well, I'm not going to tell you, because these are not because it's secret, not at all. It's just because it's a bit more technical. So I do have ideas that I need to prove right or not. And that's I would say the daily medical / scientific work. We want to publish things that are useful, that bring the field forward. But each time you want to publish something that is really useful, well, you encounter oppositions, because you face inertia. You face that it's very heavy to make fields go forward, because each time you publish something that everybody expects, well, it's easy to publish, but it doesn't have much usefulness, because in fact you basically repeat what's been done. And each time you want to publish something that really pushes the frontiers, or you think it is, well, as it were by chance, well, yeah, there are oppositions and you can't publish quickly your papers. So I think I'm one of those colleagues that has published slowly over the years, but still published, but slowly, because my papers get much more often rejected than accepted. And so what you see in the literature with my name is much, much, much less than what I wish I had published, because I had many papers that it took them years to get accepted. So the whole thing goes slowly. But it's strange to say, but I'm kind of proud of that slowness. I'm very active in my daily little schedule. I sleep not much, and I'm trying to do the best I can. And still, my number of publications grows slowly. And that slowness is, I hope it's due to the fact that each publication for me is a very serious thing. I wish each publication with my name on it would really push the field a bit more ahead. And it's not easy. It's not easy. It's not easy to do that. So I wish for that difficulty. I want to keep staying in this difficulty, publishing in this difficulty, convincing my colleagues, convincing my peers, my friends of this, of that, and the other. And so the fundamental concept of the guided self-rehab contract is really a major thing for me, but we have not talked about today of other smaller things that I tried to push, concept like spastic co-contraction, spastic dystonia, pathophysiological concept. I tried to convince my colleagues of their reality and the usefulness to know them, because it has consequences in the way we examine patients, the way physical examination is done. I'd like to have pushed this in a certain way. So these are technical things. I'm trying to push my ideas because I believe they are correct. I hope they are right. They are correct. And I try to convince my colleagues and my community that they are. And so it's a slow process. It's a long process.
Yeah, for sure. Do you think you don't sleep? I think maybe you sleep an hour, Dr. Gracies.
What's that?
I said, I think you sleep an hour. I don't know how you do it.
No, I sleep more than an hour. Well, when I was in New York and when I was like, let's say 10 years back and 20 years back, I was sleeping much less than today. I think that with the years, my need of sleep is bigger. I need to sleep more.
We all get older and we all need
That's
more.
right. But today I sleep more than I used to.
Yeah, no, but you're so dedicated into what you're doing. I mean, it's absolutely remarkable. It's made a difference on me. It's made a difference on so many other patients. And look at the doctors, that you're teaching. It's remarkable.